My name is Sarah Bass. I'm at Temple University down in Philadelphia. Um, I'm really excited to be here today to talk a little bit about what risk communication is, how people assess risk, and how that's associated with their behaviors. So I'll be relating this all to COVID-19, obviously, because that's where we are right now, in the thick of it, and talk a little bit about why people sometimes don't do the things that can protect them, especially as it relates to vaccine hesitancy. So these are the things that we'll be going over today. We'll talk a little bit about risk perception and its relationship to behavior, because it's very important in the context of COVID and what's happening right now. We'll talk a little bit about what risk and crisis communication are. So what are the differences, how risk perception has impacted COVID-19 behaviors, and then we'll look specifically at vaccine hesitancy and some of the communication strategies and resources to address that. So let's get started. So first, I'd like to talk a little bit about risk perception. In general, people are resistant to risk, although there are those crazy people, we probably all know some of them, who want to jump out of airplanes. Most of us actually resist a lot of risk. However, the weird thing is that despite the resistance, we also don't believe that we're at risk of things. So we don't think that we'll have a heart attack even if we're a smoker, or we always think that we're a better driver than other people. So why is this? Based on the information available to us, often the reasoning process induces us to think that a hazard in question is actually not a real threat. And this is especially true the more we know kind of about the hazard, because we feel we have some control over it. This is called optimism bias, and that's really just the basic idea of it's not going to happen to me. When we minimize these risks, we call this attenuation. And this attenuation may lead to potentially serious or adverse consequences by underestimation and under response because of that underestimation. And this means that we actually may take certain risks because we've decided that a negative consequence isn't going to happen to us. It's sort of a crazy way that we deal with things. If we didn't attenuate at least some things or some risk, we probably would never leave our houses because we would be afraid of everything. The problem with this is that people, when they underestimate risk, they believe themselves to be safe and invulnerable to risk. And it also means that they often don't behave in ways that would protect them. So when you feel safe, you don't feel obligated to do anything. And this sometimes leads to a divide between what experts and the lay public identify as the most important risk, which I'll talk a little bit more later about in the context specifically of COVID. So let's talk a little bit about what happens when we do feel threatened, like we do in a crisis, hopefully, and like COVID-19, and some of the factors that might increase or decrease that feeling of risk. We estimate risk usually, especially in a crisis like COVID, based on a list of things. So you'll see that here in this slide. We do this mostly unconsciously, but there are some things that actually make us underestimate risk or attenuate it, and then some things that make us overestimate that risk. Not going to talk about all of these things, but I do want to highlight a few that I think are probably the most important in the context of COVID. So the first two are control and choice. So think about something like driving, right? We always would rather drive than ride in the passenger seat because we have control over the car, and we don't think that there is as much risk when we are in control of it. A risk that we choose to take always will seem less hazardous than one that's imposed upon us. So just think of your own behavior and think about whether that's true. So, we almost always will feel more comfortable if we're in the driver's seat. Similarly, if we have the choice to do something, like texting and driving, we feel we have control over that situation, and our optimism bias is present. We don't think that anything bad's going to happen to us. We always think, well, that person can't do it safely, but I can. I only do it at a stop sign, or I only do it at a red light. So control and choice are over the process that determines the risk will probably not appear as great when that control and choice are not there. In the case of COVID-19, if we have control and choice over where we go and what we do, we're probably going to feel like less likely that the risk is real. Um, if you think about it at the beginning of the epidemic, especially on the coasts where we were not given a lot of control or choice. So their places were closed. We were told to stay home. There were curfews in some places, and these actions do take away control. So our risk was heightened during that time. As things eased, however, and more control and choice were provided, so you can start going out to dinner and sitting outside, or certain types of things are businesses are open. Um, that risk kind of starts to lessen, and the perceived risk goes down, making us less likely to do what we should to protect ourselves. Or if you are in parts of the country that really have not imposed a lot of bans or even mask mandates, you may have attenuated that risk from the very beginning. The next one is whether it's a new risk and if we have some type of high awareness. So, new or kind of exotic risks tend to be more alarming to us than those that we have experience ahead with. So, if you think at the beginning of COVID-19, it was very new and scary, our risk was heightened. Similar, the more we are aware of that risk, the better we perceive it, and then we start to get concerned. So it might be something like breast cancer that we hear a lot about versus something that, a disease that might be quite rare. The awareness is often driven by the media or other informal sources of information. So, again, kind of at the beginning of the pandemic, we couldn't get away from hearing information, and our risk was heightened. But as things go on, as time kind of goes on, the less new and exotic something becomes, and then it becomes much harder to maintain that heightened sense of risk in people. The next thing is called possibility of personal impact. So if we believe there is a possibility of some type of personal impact, any risk can seem greater to us if we or others close to us are going to be the victims. So this is why things like, the term statistical probability is often very irrelevant in the public's view. It's why in certain geographic areas that were hardest hit, the sense of risk may be higher. But now, you're kind of starting to see that risk increase in other parts of the United States. They're getting hardest hit. But again, it's hard to sustain that over a long period of time. Trust and fairness, also very important, especially in a public health crisis. The more confidence we have in who's responsible for our protection, sometimes the less we actually feel concerned. The less we trust them, the greater the concern. And this actually may be different for different people or different groups, depending on who it is they actually trust. So with COVID, as we know, much has been politicized. The messages have been very mixed. So this affects that feeling of trust and fairness in the process. And you may cause some to have heightened risk and actually some to have lower risk, which is why you see such differences in behavior across the country. Also, I think here it's important to note that people who have to face greater risks than others and aren't benefited in some way may look at risk differently. So those communities that are harder hit by the epidemic, like Black African American communities, are going to have a heightened sense of risk because they have less trust in the process. And that brings us to that word, which is process. So finally, process really is an important factor. It's similar to trust and fairness in that But it's here we're looking more at kind of the agencies and governments from the feds down to local, who are tasked with actually, putting forward the mandates around things. And the belief is that that has to demonstrate trustworthiness, has to be honest. They have to show concern about the impacts of the risk. If they don't, the risk perception is negative and trust is less. So, things like mixed messages about data, data from what's coming out at a federal level versus a local level, testing, school reopenings, the discussion around that, or what we're seeing now, which is a shortage of the COVID vaccine, and who's able to get vaccinated or not, kind of are all things that impact this trust and process issue. And it's important to note that I think that it's a time at which not trusting the process just makes people actually give up and not care what happens. It's like they disconnect from some of that. So being outraged or having fear about things can really only go on for so long. And I think that's an important point with COVID. Okay, so I want to pivot now to thinking about what risk communication really is, and see it as kind of this larger umbrella of health communication, and then these kind of subspecialties of risk communication and crisis communication. So, this larger umbrella of health communication is really just the study and use of communication strategies to inform or influence both individuals and community decisions around health. And it really encompasses any kind of information that's being used to address the health of the public. Risk communication, on the other hand, is an approach for communicating effectively in what we would call high concern or low trust situations, or in things that are very sensitive or controversial. So think about the difference in how we might communicate about diet and exercise versus how we might communicate about HIV risk or even overdose risk or substance use. In risk communication, that risk perception becomes a really key element in understanding how to best communicate with people. I think another important thing about risk communication is that our words and messages are sometimes counter to or kind of go against what the community's perceived risk is, much more so than just general health communication. So the goal is to understand, I think, that the public's risk perception is because that in a sense is their reality, and to build trust and credibility with them, they need to feel that we're understanding their issues, even if their perceptions do not kind of completely track with excuse me, with kind of the reality of the situation in terms of what actual risk is. So I always think in this context about my 90-year-old grandma who was convinced in 1988 that she was going to get HIV. That was her perception. And just dismissing her fear was not going to convince her otherwise. So, without kind of addressing a lot of this risk perception, the public's not going to hear the risk message that's being conveyed. And finally, crisis communication is kind of a sub branch of that risk communication. It's where you're using the principles of risk communication but in a crisis, which usually is a timed event, meaning that it lasts only for so long. This is, usually a major kind of unpredictable event that has potentially pretty negative results that can be a threat to the public. So in public health, this is usually an outbreak of disease, but it also could be some kind of a disaster that affects health. So we might think of things like Ebola, COVID, Spanish flu, but also things like floods or hurricanes or other kinds of disasters. And that time component is really critical here as it kind of requires specialized communication that provides very concrete information in a way that's easily acceptable. So now I want to kind of bring these two things together, this idea of risk perception and crisis communication. In a crisis, our brain is activated to respond. And when our limbic system is activated, we tend to respond quite emotionally. And people who are upset tend to think negatively. I think we can probably all relate to this. We've probably all had this happen over the last 10 months or so at some point. It also produces a lot of mental noise. So just having a lot of things that we're thinking about at the same time. And when people are stressed and upset, they often have they have a lot of difficulty kind of hearing, understanding, and remembering information. It's actually estimated that that noise reduces our ability to comprehend information by about 60%. So just think about that. And I think importantly, when people are upset, their perceptions of risk are heightened, and what they believe or think is often very different, as I said earlier, than what experts might be telling them. So the sources of information become really important because if they're feeling upset, they're going to latch on to communication that makes sense to them. And sometimes what makes sense to them is not what's coming from experts. And so what happens then is that instead of kind of trusting facts about what's going on, people in a crisis will instead trust those that they believe have empathy and caring. And they make this distinction quite quickly. So some of the estimates are that within 30 seconds of hearing or seeing someone, they're going to decide if that person is empathetic or caring. This is important because, if we think about who's providing the message in the crisis, if you have the most knowledgeable person in the world, but the public doesn't think they're empathetic or caring, their message will get lost. So you can see here that competence or expertise is only about 15 to 20% of how people trust others in what they're saying. If you think about it in terms of the risk perception factors that I talked about, the number one thing that affects how people deal with uncertainty during a crisis is trust, followed by things like control and fairness. So these really become the most important, most likely way that they're going to interpret risk information. And if they don't trust who's providing that message, it's going to be very difficult to get through to them with the information that you want them to have. This can have pretty serious consequences for who people believe. So, this was a study that looked at source credibility and trust. And as you can see, the Surgeon General has the most source credibility and trust in the public. Now, I don't know if it would be the same right now with kind of what's happened over the last 10 months, but when the Surgeon General is not present or is not allowed to be in charge of the public health response, it gets a little murkier. And there's a lot less trust, which means that public engagement and usually compliance by the public of what is being asked of them is probably going to go down. And what happens in the absence of that authority, I think, is just the feeling that no one is in charge. And that becomes a problem with crisis communication. All right, so that kind of sets the stage for thinking about these concepts of risk perception and risk and crisis communication. Now, I want to pivot to kind of talk specifically about how all of these things affect our response to COVID-19, and then specifically looking at kind of vaccine hesitancy issues. So I'm sure we all remember at the beginning of March of last year, And as things kind of move forward to May, much of the country was on lockdown. We saw lots of images with healthcare workers, people in masks. We saw things like mass graves being dug. Um, and we had started to see a lot of pushback around public health mandates and recommendations. And we still see many of these images now. I mean, especially as the vaccine has started to roll out, we're starting to see these images over and over again, in news and in social media. We also have lots of messages and lots of communication about how to protect ourselves. So, from New York State to Pennsylvania to federal, lot of information out there about COVID. Counter to that, however, is we also have a lot of media coverage. So we have media coverage that's happening literally every day, 24/7, with lots of people talking, some of whom may or may not know what they're talking about, and lots of people saying different things, right? The problem with this is people have short attention spans in a crisis. They have a hard time processing information, and there have been so many mixed messages. We have so much communication happening, and coming from multiple sources, and much of it has been contradictory. So here's, this is just a few things out there. I could probably have 10 slides full of all of the mixed messages that have occurred, where we hear one thing from one level and something else from another level. It's hard for people to keep up with that. I mean, it's hard for me to keep up with that, and that's what I do for a living. And, on top of all of that, what I would say is kind of tick-tock, right? Time goes on, and we want to all get back to normal. We want to get to that state of optimism bias. So as we moved into the summer of 2020, and now into 2021, we, have seen a lot more pushback about complying with directives. People can only have a heightened sense of risk for so long. And the longer it goes, even as we are racking up, both cases and deaths, the harder it is to stay in that kind of heightened sense of crisis. And the more we want to say to ourselves, well, it's okay if I go to grandma's house for Christmas, or it's okay if I go to a bar, or it's okay for me to go on vacation. These are normal activities, and people, human beings, want to feel normal. So it really is kind of a cascade that happens in affecting public behavior. So we have all these factors that kind of affect public response to COVID. We have all this mixed messaging and kind of poor communication that's happening. And then time overall is just not our friend, for people to kind of stay in that heightened awareness. Which brings us up to present day, which is thinking about the new problem that we're starting to see, which is vaccine hesitancy. So, we know in public health that to be effective, a certain level of vaccination or immunity has to occur to create enough herd immunity to protect the public. So in the case of the COVID vaccine, the estimates are that we probably need to reach at least 75 to 80% of the population to create that immunity. Some say even more like 85%. And I think that might change as, we have more variants that come, and, the vaccine's effectiveness goes down. We may even have to have more people. So that's going to be stymied if enough of the population obviously is hesitant to take the vaccine. So in general, vaccine hesitancy is categorized by this continuum, from those who accept all vaccines with pretty much no hesitation, down to those who maybe accept but might delay or refuse some vaccines because they have some hesitation, all the way down to the tip, which are really those who refuse all vaccines or deny that vaccines have any kind of benefit. And what I would say is that there are some differences between general vaccine hesitancy and what we're starting to see in COVID-19 vaccine hesitancy. So the World Health Organization has what's called the Euro Vaccine Communications Working Group, and they propose what they call the 3 Cs model to explain vaccine hesitancy. So this is confidence, which is defined as the trust in the effectiveness and safety of vaccines, complacency, which is where the perceived risks of vaccine preventable diseases are low, and then convenience, which is just defined as kind of the physical availability and ease at which vaccinations could happen. In the case of COVID, I believe, the majority of the hesitation is coming from that first bucket, that confidence in its effectiveness. Um, and it's driven by a couple of things, I think, including the speed at which the vaccines have been developed, to kind of the lack of trust in those in charge of the effort, both at the federal government and at pharmaceutical company levels. And most surveys suggest that about 30 to 35% of the population does fall into this category, in people that say they probably or definitely would not get the vaccine. And if all of those people don't get vaccinated, then we do fall below where we need to be to produce that kind of viable herd immunity. The good news, so there is a piece of good news, which is that vaccine hesitancy seems to be going down a bit. As you can see here, this was a survey that was done by the Kaiser Family Foundation, and they did this in August and then in December of 2020. And those who said they would definitely or probably be vaccinated did rise from about 63% up to over 70%. And the number who say they definitely or probably would not get vaccinated has fallen to about 27%. So still too many, right? So still more than 1 in 5, but we are starting to see it slightly go down. So who are these folks in that kind of 1 to 5 piece? Most of the cross-sectional survey samples have focused on kind of socio-demographic characteristics of hesitators, and they seem to indicate that Black and Brown groups, especially Black African Americans, but also women and those who are younger, are most likely to be hesitant. In addition, having lower education and income levels, and not having received the flu vaccine in the last year were also predictive of those who said they would not get vaccinated for COVID. In a study that I did recently in New York City, Miami, and San Francisco, there was also an interesting correlation with those who didn't pay attention to COVID-related news. And in people who said that they were dissatisfied with their own health or their own access to healthcare, which I think would be an important correlate to kind of think about as well. If you think specifically about why Black African Americans are most likely to be hesitant, really all we have to do is look at both risk perception and history. So I think a significant lack of trust in the federal response, and the leaders have kind of fueled a lot of this, especially because of, the Black community has been hit so hard by COVID. And then historically, the Black community has rightfully felt exploited by healthcare and research. So this plays out in the data. There was a survey by Kaiser Family Foundation also that was done with Black African Americans, and they found that only half of the adults surveyed said they would definitely or probably get vaccinated. So that's, more than 20 percentage points lower than both Hispanic and white adults. And interestingly, these differences are kind of independent of political leanings and kind of actual risk factors for infection. So, if somebody had a secondary heart health condition, for example, or they lived with an essential worker, which would increase their risk for COVID, that, that really did not impact who said they would or wouldn't get that vaccine. When they were asked why they would not get vaccinated, about 35% said that they distrusted the healthcare system and the government, and a significant number said they just did not trust the vaccine in general. I think another interesting note is that some new research that just came out on Monday, actually, from the Brookings Institute, seems to suggest that in the Latinx population, they're not obviously all the same in their vaccine hesitancy. So depending on kind of where they come from or where their family descended from, we're seeing some differences in vaccine hesitancy. So overall studies have shown that about 28% of Hispanic or Latinx population said that they would be unlikely to get vaccinated. But those who were especially of Puerto Rican or Mexican descent were more likely to be hesitant. So people of Puerto Rican descent, for example, were about 7% higher in saying that they would not be vaccinated, up to about 35%. And these two groups are the largest national origin groups among Latinx in the US. When this group was asked why they didn't get vaccinated, reasons for not vaccinating were very similar to those in the Black community. So there were concerns about the safety of the vaccination, worry about side effects or that it will be ineffective, and just general distrust of medical research. But importantly, I think here, this group also expressed a lot of concerns about both the treatment of immigrants in the US and distrust specifically of the Trump administration as reasons for not wanting to get vaccinated. So now I take a little academic turn because I think this is a really interesting way actually to think about vaccine hesitancy, which is through this lens of diffusion of innovation theory. So diffusion of innovation theory explains, how the public adopts new things. It's used in a variety of different fields, but it can be applied quite well in public health. And it postulates, what the rate of quote unquote adoption would be of something that might be new. So in this case, it might be getting vaccinated. And it's dictated by what they call these attributes of the innovation. So these would be things like, is it better than what it's replacing? If you can see others who are doing it or using it, is it compatible with the audience's values and past experiences? And generally, the more these attributes are positive, the faster the innovation is adopted in a population. Another piece of the theory, though, is to note that the public can also be separated into these 5 different groups. And that if you can get early adopters who tend to be leaders or who are looked up to in communities, if you can get them to adopt something, you're going to more likely be able to also get the early and late majority to adopt as well. And those are the biggest chunks of the population. So what that means is that if you can get community leaders to be quickly vaccinated, a significant chunk of the rest of the community will come on board. So like Robert and I were just talking beforehand where he said, he has some friends who are highly educated who said, no, I'm not going to get vaccinated yet because I don't have enough information or I don't think they know enough information. They probably would sit in that kind of late majority. Whereas if they saw a lot of people get vaccinated, often you'll get them to come on board more quickly because they feel like there's safety in numbers. The interesting thing here is that, what we might actually not have to focus too much on these laggards. So you can see the laggards are about 16% of the population. If you look at vaccine hesitancy, you have about, between 25 and 30%, then, maybe we don't have to worry as much about this group because if, we might be able to get to herd immunity if we pull this early and late majority in. The problem, however, is that our vaccine strategy so far, where we're having these kind of very specific certain groups get vaccinated at a time, actually hinders this process, meaning it's much harder to get a large group of early adopters vaccinated if they're being kind of parsed out among the different vaccination groups. Um, so I just, I bring that in because I think it's an important way to kind of think about vaccine hesitancy and from a communication standpoint, who we need to really focus on. For now, I think we do need some real risk communication strategies to combat vaccine hesitancy, obviously. Risk perception research shows that heightened or lowered levels of emotion can interfere with motivation and kind of willingness to engage in preventive health behaviors that may increase our susceptibility to or endorsement of misinformation. And so what we need to do is try and find a balance between, you know, too high in emotion and too low in emotion. And that really does make our job harder because we know that mixed messages and misinformation have been really rampant in the COVID crisis. I think, and I've mentioned this a couple of times, but I think it's really important here in the case of COVID and what's been happening is that how information is conceived by experts is often very different than how it's perceived by the public. So, as experts, as public health experts, we often look at an issue much more dispassionately. We think about the data, and we think that the data should be able to speak for itself. We look at statistical significance. We look at the progress that's being made, and often that happens incrementally with, evidence-based hypothesis testing. We use the scientific method. So we often say phrases like, most likely, or we say things like, we don't have results from a double-blinded placebo trial. The public just doesn't think like this. They will hear information about animal models and assume that the same will happen in people. Anecdotes hold the same weight as often scientific results and have a kind of they say attitude, meaning, something they see or hear, especially on social media, is taken as truth or reality because often these short posts or videos are often much better at communicating than experts are because they speak in the same way as the public. All you have to do is get on YouTube and look at some anti-vax videos. They have figured out a way to get across information, often that's totally bogus, but that feels right or real to the viewer. And this is kind of a subspecialty of research. If you're interested in this at all, check out, I've put in the slide here, Tim Caulfield's work. He's up in Canada, and he's done a lot of analysis on these types of communications and has really some interesting things to say about that. And then I also think another real important piece with COVID communication is to understand how important fear is, and realize that fear really is a very powerful motivator. It's a basic human emotion, protects us from danger, but it also impacts risk perception. So, in a crisis like COVID, there's this kind of subtle balance between fear, facts, and trust. And it's really a seesaw in which trust is that fulcrum and facts and fear balance each other. So it's critical that the public trust the information that they're getting. And that means we need to communicate with the public in a way that works for them, that addresses their risk perception as their reality, and addresses those fears that they have directly so that they're more likely to trust the us and the people who are providing information. With these things in mind, we have to be prepared and proactive in thinking about vaccine communication. So I'll give you a couple of resources and a couple parting tips on this one. There are some resources on vaccination. The CDC toolkit is available on their website. Unfortunately, right now, it really is just focusing on communication with healthcare workers and those in Group 1A. I'm hopeful that they'll expand some of that information to other populations soon. The other here is a guide that was put out by NIH. It's actually a really good guide written by great people who work in risk communication. Um, a lot of what's in this guide is what I've talked about today. So it's a really good place to start to have some thought processes going on about how the public is responding. Honestly, so far there isn't a lot else out there that isn't either homegrown out of organizations or health departments. So this is kind of what's there from a federal level. I think there are some things to think about as you are creating communication around vaccination that kind of addresses some of what I've been talking about with risk perception and some of the key people who are most likely to be vaccine hesitant. There's a really good guide from the Public Health Institute. I put that link here too. And I would go to that website because I think it has some really good thoughts about kind of next steps with communication. But I think, there are kind of 5 things that I would say that you really need to be in the back of your mind whenever you're doing this. So first is just to, meet people where they are. As I've talked about, many of these groups have very real reason to be resistant to vaccination or feel that their communities are being taken advantage of. So we have to listen to these communities and acknowledge their fears and not dismiss them. The second, I think, is to really try and clearly explain the vaccine process. Because I think, we've talked about mRNA vaccines versus traditional vaccines, and we get kind of kind of mucked up in the stuff of the science, and we really need to be better at kind of clearly explaining that process. So being straightforward and providing all the information that we know. If we don't know something, that we say that we don't know that thing. People actually are accepting that you don't know and won't accept that you've lied to them if they find out that that's the truth. Third is to prepare for some discomfort and distress. I think, we in public health have to understand that it exists and to embrace it in a way that, says, yes, I understand how you're feeling. And we have to be open to it and allow people to articulate how they're feeling. And then fourth, I think, is just, building relationships with trusted messengers those communities. That if we look back at diffusion of innovation theory, we need to find those stakeholders who are going to be the best spokespeople for those communities. Because we're not often perceived to be from that community, and we probably aren't. So we probably aren't the people who are best at communicating about vaccination. So trying to enlist those early adopters and those champions to provide information is going to be a better strategy. And then last, I think, is just, name racial equity explicitly, especially in areas where this is going to be a real problem with vaccine hesitancy. We need to be kind of proactive in addressing racial equity, and we need to concede, the past issues and be upfront about that. It's just another reason, having people from that community as spokespeople and champions is important. Overall, risk perception can be a tricky thing. The public generally will comply if they feel they're personally affected, if they have little control or choice, if they trust the information they're getting, and it doesn't go on too long. If they're in a state of crisis, they do want to protect themselves. But if any of those things are affected, and the longer something goes on, the harder it is to kind of be prepared and stay prepared. So I think I will end on this, which is that, public health events can be scary. And people can be seriously affected by negative risk perception to the point at which they're either so scared that they don't comply or not scared enough that they don't comply. So, risk and crisis communication are really important to counteract this. But it can be really difficult in this kind of 24/7 news cycle when there are multiple messages, multiple messengers, changing messages and contradictory messages. And I think that's why COVID has been so challenging and why it's been difficult to get people to do what we want them to do. Despite everything, however, I want to acknowledge that the real heroes in the fight, and believe me, I count all of you working on the ground in public health, um, that these heroes exist and are doing the good fight every single day. So let's hope that we learn from our mistakes and are able to give all these heroes a break. And then perhaps we can all get back to normal, and to that state of optimism bias that we're wanting to get to. So thanks so much for listening. If you're interested in kind of some of the work we're doing in my lab, or you want to talk about anything that I presented today, please reach out. Feel free to email me, or look at our website or our social media channels. And I think I'm in good shape to then